Hi, thanks. I'm Erin Leiman. I'm coming to you guys today from North Carolina, and it's a real honor to be speaking here today. No disclosures here as well. So today we're going to sort of briefly touch upon three topics. The first being exsanguinating hemorrhage, then coagulopathy and trauma. What does it mean? What is the extent of it? And then finally, to talk about massive transfusion and the development of massive transfusion protocols. So we all know trauma is common. It's something that we see all the time and is a leading cause of morbidity and mortality, especially in the United States. And unlike exsanguinating hemorrhage, traumatic brain injury and multi-organ failure can actually take several days to lead to death. However, exsanguinating hemorrhage is one of the leading causes of, is a potentially reversible leading cause of death and trauma, and usually occurs rapidly within the first 2 to 3 hours of presentation. We've all heard also of the lethal triad. That's hypothermia, acidosis, and coagulopathy. And the discovery of this and its role in death led to the development of the resuscitation or damage control, which is a resuscitation method that was really partially a surgical technique, but was also a resuscitative technique that focused on the reversal of coagulopathy and hypothermia. And in this theory, coagulopathy was viewed as a sequela of both bleeding as well as hemodilution from resuscitation. However, further research started to show that up to 1/3 of patients upon admission were already coagulopathic. And it's important to note that coagulopathic bleeding is different than just bleeding from exsanguination from an injury itself. Coagulopathic bleeding is diffuse, it's difficult to stop, and usually results from a failure to clot at the capillary level. It's a very complicated, multifactorial reason that this occurs, partially due to the activation of the hemostatic cascade, as well as activation of anticoagulant and the fibrinolytic pathways, in addition to bleeding and then just hemodilution from resuscitation. And the discovery of this sort of multifactorial and multivariable pathways has really led to a more recent update in damage control and how we proceed with resuscitation. At this point, our goals are to minimize crystalloid fluid, to minimize hemodilution, but also to rapidly address the source of bleeding and then to prevent and correct ongoing coagulopathy. So this has sort of then led to massive transfusion. And there's no great definition for massive transfusion, but it's thought to be at least 10 units of blood products in the first 24 hours. And it is required in at least 3 to 5% of civilian traumas and up to 8 to 10% of military traumas. And at least 25% of trauma patients requiring at least 1 unit go on to require a full massive transfusion. And of course, these patients have a pretty high mortality. Requiring a blood transfusion is also associated with increased mortality. So when we think about massive transfusion, there's 2 really important studies to keep in mind. The first is the PROMPT study, and this came out in 2013, and they found that earlier use of higher ratios of plasma and platelets in a balanced ratio to blood led to improved survival in the first 6 hours. It's important to note that this study did not really focus on consistent ratios. So there was no one set protocol of how they were actually transfusing these patients. But they did note that most institutions, this was out of 10 institutions, were using either a 1:1:1 or a 1:1:2 ratio. And again, this is plasma, platelets to RBCs. And it's also important to note that platelets sometimes may be designated as 1 unit, but it is often a pooled sample. The work with the PROMPT study then led to the PROPER study, which was published in 2015. And this study actually looked at making the ratios more consistent and trying to determine if there was a better ratio that we should be using. And so they directly compared a 1:1:1 to a 1:1:2 ratio. And they found that although that there was no mortality difference at 24 hours or 30 days, there was an improved time to hemostasis, and that was in the OR or IR suite, as well as less death due to exsanguination at 24 hours. These two studies led for them to conclude that a massive transfusion should start within minutes of arrival and to use a balanced ratio. And they went on to say it should ideally be a 1-to-1-to-1 ratio. So if we're supposed to be starting within minutes of arrival, though, how do we know? How do we know which patients would benefit from a massive transfusion? And even though many institutions have massive transfusion protocols, they don't always clearly state when these protocols should be started. Fortunately, we have some evidence to guide this. Unlike earlier studies that focused on needing laboratory data as well as mathematical calculations, the assessment of blood consumption, or the ABC study that was published in 2009, looks at predictors of requiring that are all easy to measure in the emergency room. These included penetrating mechanism, positive fast, blood pressure less than 90, and a heart rate greater than 120. What's also interesting is that this was actually one of the inclusions parameters for the proper study. So the proper study said that if patients met the ABC score and required 1 unit of blood either in transport or immediately upon arrival, they were included. So this study has gone on to be validated. So for example, I sort of wanted to bring it back home to Duke and sort of what we do, and sort of that's exactly how this talk sort of was born when I started to kind of look at these things and what we do. And it's important to note that each institution has their own protocols. We have 3 rounds, and we actually ended up having to come up with placards to put on a board because it was becoming very, very confusing. And it's important to note that at our institution, we say once you start a round, you should complete that round. We also include TXA as part of our MTP protocol. And remember, for trauma dosing, it's a standard dose. So final thoughts. Exsanguinating hemorrhage is a very common cause of death, especially early on, but it is potentially reversible. Up to 1/3 of these patients are coagulopathic on arrival. Start MTP early, use balanced ratios, and it's important to note your own institution's guidelines. Thank you.